I'm interested in your background, how you got here. Well, let me ask you this. How did you get into this?
Yeah, it's interesting. COVID was a transformative period for me. Up to that time, I was doing research on psychiatric drug efficacy, harms of psychiatric drugs, specifically antidepressants. I was going to create a position statement, which I eventually did, for antidepressants because we just saw so many people on them haphazardly prescribed.
When did you start noticing that?
My entire career. I mean, I can go back to probably 2000 when I was working in Children's Psychiatric Hospital. I saw what they were doing to young kids who were traumatized. So I was going through all my training. I always took, a very critical eye, but it just started to expand dramatically post 2010, and then approaching 2020, dramatic increases pushed by primary care. And then by the time the pandemic hit, of course, everybody got an antidepressant. And so I was studying how the drugs came to market, the trials, talked to experts around the world, and I knew I had to start a podcast. So that's kind of how—
that was your leap into that.
That's how Radically Genuine got started. And it's interesting, my path, my journey right now takes me into all different areas. It's not only psychiatric drug harm and mental health, but it's really how it's been so institutionalized for corporate purposes. And it's no longer really about science anymore. It's a distorted version of science. And so I'm interested also in how medical professionals are trained, because I've sat down with so many of them to say, hey, what you're doing is harmful. There isn't safety. There is no efficacy to support what you're doing. I see the eyes get glossed over, and I see them all repeating the same messages, which got me in a direction to say, all right, how did we get here? How are we blindly just accepting the medical authority? The COVID vaccine was a whole nother deep dive for me, and it just aligned well with what I knew about the psychiatric medical establishment and how we've medicalized all aspects of our culture to push drugs and diagnoses, and overwhelming, there's harm. And every available statistic will demonstrate that our mental and physical well-being is on a dramatic decline over the course of decades. And so it's a wake-up.
Well said.
And so you reached out to me after I put an article out there. I think it was on my Substack, but then it got posted on the Brownstone.
Yes.
And that was really about how did your pediatrician and primary care doc become a drug and vaccine enforcement agent?
And that was right in the aftermath. I had done 2 lectures at Georgetown University, which were received very differently. Basically, same lecture. One was the lecture is titled Spikeopathy, Novel Virus, Novel Therapeutic, Novel Complications. And I was speaking to first a group of college graduates that were interested in going into medical school. Some were going to go into pharmaceutical research, and they were master's students at the Pulmonary Hypertension lab with Dr. Suzuki at Georgetown University in Washington, D.C. And they seemed very curious. They were a little skeptical, but I could see that they were critical thinkers. We had a good conversation. I think that maybe I swayed some people. And I start this lecture by saying I have a mental disorder where I believe if I just present enough facts in the right order that I'll change minds. And I have this false sixth belief, this delusion that I can do that. But it seemed to work for this one. So I came back 2 weeks later, and I spoke to a group of rising fourth-year medical students who had specifically picked a seminar on probably the most boring topic in medicine, which is pulmonary hypertension. It's one of the most obscure. It's easier to explain now, but it was sort of an oddity. But the professor there, Yurichiro Suzuki, is a world authority in basic science research with this disease process. And so they had chosen to do a seminar with him, and he invited me to speak, both as a practicing physician. He thought I'd have some insight there, and as a patient with this. And I tried to tailor it more to the students, saying, I was in your shoes once. this is what it's like to be a doctor, and some things I learned through my medical career. So I had that same glassy-eyed, sort of shell-shocked look, and I was surprised. I obviously misread the room. I was perhaps too radical and perhaps too genuine or some combination thereof. But I'd started the lecture by saying, when I was in that position in my training, and I've been a physician almost 30 years, that at least 80% of patients trusted us. That ratio is probably flipped. It's under 40%, maybe under 20%. And I said, well, a big reason why is a lot of what we're doing isn't working. Patients are sicker, people live less, and the mistakes we made with the response to COVID are a big part of that. They've lost trust. And one of the important parts of my training, maybe when I reflect back, one of the most important parts were I had some fantastic physician mentors. And the lesson was, you have to learn to admit error. And if you can't, you can't correct mistakes. And I had some really, really phenomenally trained, or just phenomenal professors who were pioneers in anesthesia, who could make a mistake and laugh, and they would lead by example, and they would catch small mistakes before they became big mistakes. And it was imperfect, but it was still a culture of safety. So I was trying to relay that to the students and saying my experience has been, if you're a physician and you made a mistake, usually patients are very understanding and forgiving. And so
Unless they're dead.
Unless they're dead.
Those are larger, big mistakes, right?
The big
Where
mistakes. And
the public has a hard time forgiving.
Absolutely. But you want to correct that before you get there. And so I try to have a very positive message and say, look, what's changed in my career, we were training as young doctors, and we were explicitly told, hey, you don't have feelings. And we would just sort of nod, be like, yeah, that sounds right.
Like your robots?
Yeah. And I think it would shock, I understand you have an international audience, and it's probably hard to convey that medical school training. It would be very rare that I'd have a work week that would be less than 80 hours. It was usually 100. And I told the students, like, look, you have to study as if someone's life depends on it, because it does. You should train very hard, but we don't want to do it so much that you lose your humanity, you lose your empathy, which will happen in the training. That you really want to allow space to care for yourself, because if you lose yourself, you're not going to be an effective physician.
Yeah, let me ask you a question about that, about losing your humanity. Depending, I guess, on your specialty and the type of work that you're doing day to day, you almost have to become somewhat desensitized, I would imagine, because of what you're facing. I mean, you're facing life and death situations. You're experiencing the heartache of people being provided terminal diagnoses and death in emergency rooms, having to talk to families. I've always imagined, like, how does a medical professional then learn how to cope and then readapt and adjust back into their civilian life, for the lack of a better word, having to be exposed to that level of trauma on such a consistent basis?
That is an outstanding question. I knew I was in trouble in training when I had a patient had a complication. They were learning stenting technology, and they had put a coronary stent in, and it had caused bleeding around the heart, and it caused a pericardial tamponade. And so I was called to this patient's room, and I put my stethoscope on, and I heard the last heartbeat, which is a very confusing thing, because for a moment you think, is the stethoscope broken? Why don't I hear another heartbeat? So I caught the last heartbeat. And there was a code. We tried to resuscitate, and it was a fatality. And I knew I'd hit rock bottom there, because it didn't hit me at all. And I only cried later after that when I realized just how much it didn't affect me. So there was a process of recovery. When I finally got out of residency, so there was this author, Malcolm Gladwell, and I think he said it took about 10,000 hours to become an expert in something. Well, except in medicine. So for anesthesia, I added it up, it's well over 30,000 hours. for something like neurosurgery, you're well into the 40,000s of hours. It is an incredible amount of training.
Let me challenge that for a second,
Sure.
because I've thought deeply about this, because we're subjected to whatever the training is at that particular time. So the longer you work under a certain paradigm, whether that paradigm is true or false, you'll become an expert in it. But if you're working in a certain specialty or under a paradigm that ultimately has shown to either create harm or is part of a general construct that is missing so much information, it's a flawed system, then essentially you become an expert on the wrong things, right? So it's not just about hours that are put in, it's about truth. And that's what scientific process has always been about. It's the search for truth. And this is the question I have for someone who's trained as a physician.
Yes.
Is my experience is that physicians have a hard time saying, I don't know.
Yes.
That they're almost taught to have to be the expert to inspire trust with your patient, because that's a major factor, right? To get adherence to medical advice, like we've heard that word, adherence to medical advice, like you have to follow a rule. I believe ultimately that's led to us moving further away from the scientific process and informed consent. But what is the experience of a medical student who is taught that this is the best available evidence, and then the confidence level that they're supposed to display?
Well, it's changed. And so I mentor a medical student that's almost graduated now, and maybe he mentors me more because it's changed so much since I trained. So critical thinking used to be of value. And they used to say half of what we teach you will turn out not to be true, but it wasn't because there was a corruption in the journals. It's just because you're going to find more evidence. And I think the training, part of it was, we can talk about valid suffering versus invalid suffering in this kind of training, but there is some value in seeing a lot of medicine and doing a lot of cases. So my specific, I'm lucky, I get to be an anesthesiologist, and that places me a little bit outside the system, so I can see it from a different vantage point. So my job is to get people through surgeries by inducing reversible comas or using regional anesthesia to render parts of the body insensate. So I relieve non-productive suffering, where your job in many ways is to help people through legitimate productive suffering. And it's interesting that we've met in the middle here, and we see the same things. So the other thing with anesthesiology is you get to be a specialist, but you cover everything from premature babies to elderly people, or even people getting procedures for palliative care, and everything in between, inpatient, outpatient. Our training involves a lot of intensive care unit training. We take care of often the sickest patients in the hospital, and then we manage their physiology during surgery, and then the interaction with my anesthetics. So I don't have that same level of having to follow guidelines and indoctrination that you might see today in some of the schools. And so that gives me a unique perspective. And it's also, we'll get to it later, is why would an anesthesiologist see the problems that I see? And I think you alluded to it in your Brownstone article, is that there's an atomization, or the subspecialties are so separated now that it's hard for doctors to put the whole together.
Yeah.
And I'm always dealing with the complete system.
So let me ask some questions about that, because I'm always curious about the thought process of someone who chose to get the mRNA COVID vaccine, which you did, which is going to kind of kick off our story.
And I do want to get back. I'll get to how do you heal from the trauma of medicine. I haven't forgotten that. We'll get back.
Yeah, we'll get to that. This might actually walk us through that. I believe approximately 80% of Americans got at least one dose of the mRNA.
Correct, yeah.
So there's about
Maybe,
20% who did not. I'm in that camp. I did not. None of my family members did.
I'm happy to hear that. It took guts.
Yeah,
Tell me about your
guess.
thing. What was so how did you manage to avoid it? What was your thought process?
Okay, so I was scared in the beginning, like anybody else. I think when March hit, we didn't know really anything, and then the health authorities are kind of shutting down the world. So of course there's this sense of uncertainty and anxiety. But I think that was quickly replaced with some very clear data. First of all, most people who are going to obtain COVID, going to be infected with COVID, are going to experience minimum symptoms. And of course, your life is not threatened at all, right? So if you're relatively young, you're healthy, you're not on multiple drugs, you don't have comorbidities, you're not obese. I mean, it's less dangerous than the common flu that you would get in any wintertime. So that data was really, really important to me. So, okay, the question is, why would I do this instead of obtaining just natural immunity, exposure to it? And I quickly came to the conclusion it's better to get exposed to it. Then the second thing was, all right, they're asking us to be injected with a novel technology. So even if I believed in the original premise of vaccine science, right? Let's say I didn't know anything about the adjuvants. I didn't know anything about the harms. I didn't know anything about how a vaccine came to market and how they're evaluated. I was just conditioned into American society that vaccines themselves are a medical miracle and they save lives. I would have still asked the question, well, this isn't the typical, what we call vaccine. This is more representative of a gene therapy.
Oh, precisely. I mean, there's nothing vaccine about it. When I give my talk, I'll draw a clear line that this is a mRNA therapeutic. It's not a vaccine by any traditional means. And the way I'll present it to the students is I'll just say, well, who here in the room has had a polio vaccine? Every hand goes up. And who has had polio? No hands go up. Not that there could be some problems with the vaccine there, but it's rare. Who in the room, has anyone managed to avoid the mRNA spike product? And no one has. Every hand goes up because it was mandated for the medical schools. And it would be really rare to have anyone in medical practice. I know of one person that managed to avoid it, but it's rare. Almost all of us were exposed to this. And then you ask, well, who has had COVID after that? Every hand goes up.
Yeah.
And then I ask, who has had some lingering problem from this, especially shortness of breath doing things? And usually about a third of the hands go up. Mm. So you were correct. This was nothing. And so my thought process was anesthesiologists had a very healthy respect for COVID because we were managing airways during this. And I think a lot of the intensity of the illness you would get with COVID had a direct relation to how much viral load you were exposed to. So if you have a sick person and we're intubating, you can get a lung full of COVID and get very sick. And with SARS-1, the first 2 deaths in North America were anesthesiologists in Toronto that took care of the patient. So we had, I think, a healthy fear of it. And we, with limited resources, did the best we can, taking precautions. My hospital, at the time, I was working in Frederick, Maryland, down the street from Fort Detrick, not affiliated with it at all, but it's another interesting coincidence in this whole line of improbable events. The OR had, almost everybody there probably had COVID very early on. I think that would be 2020. But then the mRNA product comes out, and we realized we're taking a leap of faith. Now, I probably researched it way more than most physicians, so I had already known at that point that it didn't stay in the arm, that it did distribute throughout the body. And it's really surprising I found that out. And I knew it had been trialed twice, I think with Zika and rabies virus, and had failed. So this was a tremendous leap of faith. But where I live is a nidus of National Institutes of Health. There are research scientists with FDA and scientists at Fort Detrick. I mean, world authorities on this. And so this was a leap of faith that this product was going to help.
So the willingness to take that risk. Mm-hmm. So going back to other reasons why I made the decision, where other members in my extended family at that time did take the COVID vaccine and thought I was being reckless by not taking it. Which was always fascinating to me because, and this is, coworkers or friends, is because people knew nothing about it.
Right. Well, this is a new product. You are the factory for the protein. Now that when I know more about what went into this, it's just stunning that this was ruled out. At the time we realized we were part of a big medical experiment, probably the biggest in the history of the world. And it went badly.
Yeah, and that's the best version.
That is the best version.
The best version is that it was experimental and people are doing the best they can, and we're trying to prevent disease, and we're trying to advance medical science. And I don't believe that narrative.
Yeah,
either.
I have now, with researching this in detail, I try to come up with an innocent explanation, and I cannot.
Yeah, and that's part of the narrative I think you'd have to continue to adhere to. Like, if you've been in the system and you've been taught in the system, and you have what's called authority biases, which is the reason why 80%.
Well, explain authority biases. I actually don't understand that.
Yeah, authority bias is it's a cognitive bias, an intentional bias, where if someone is in a position of power or authority, like they're called an expert, they wear a white coat, you're less likely in any way to challenge any of their beliefs. You're going to adhere to what they tell you to do, assuming they know more than you. Yes. It's a handing over autonomy and trust to someone who's in a position of power. And it's part of a psychological operations and brainwashing mechanisms that are used in CIA operatives around the world. What we know now, propaganda in our own country, is that they can push that on us. And that's what stood out to me as a psychologist right away.
Oh, so that was the red flag for you.
Well, I knew it was bullshit when they started to use those operations, right? When they started to put anyone who was challenging it, which even they're like epidemiologists like Jay Bhattacharya, for example, or Robert Malone, one of the original patent holders of mRNA technology, they start saying, like, hold our horses here, let's evaluate this, here are the problems, here are our concerns, here's the data, here's why we shouldn't do it. And then what happens? They're discredited, immediately. Like, their profiles are taken down and changed on Wikipedia. Like, you see the evidence of the entire mass agenda and propaganda on the American people. And most of the people I was coming in contact with just said, well, what are you talking about? It's the vaccines. They've been safe for centuries. They didn't even know it was mRNA technology because they used the word vaccine, So that's the sad thing about human beings, is in times of stress, if you can induce a degree of stress, they're more vulnerable to the authority bias. They're more vulnerable to being controlled. And then you saw it because there was, you needed to be in the camp of safe and effective. You needed to be in the camp of science. And you split people up into two camps against each other. It's the conspiracy theorists. It's the anti-vaxxers. It's those who are anti-science. And then it becomes virtue signaling. You see in the social media profiles, is you have like vaccine needles, in your profile. So that's the psychological mechanism that was really at play here. Yeah. And thank goodness for the rise of podcasts during that period of time, because you got to hear from alternative experts.
You must have been later. When were you facing that pressure? That was probably March, April 2020. It was a little 2021. Probably.
Yeah, it was actually later, because if you recall, the vaccine didn't come out until late 2020 into 2021. So I wouldn't even have been eligible for the vaccine until, I believe, spring of 2021.
Yes.
So, I mean, you're getting the pressure then, right? At this point, I've already, I guess I had COVID, right? I had the symptoms of COVID. I tested positive. There's all, there's problems with that. But I recovered very, very quickly. So, I would have had a natural immunity. And so the idea that I should go get a novel vaccination was
absurd. Well, what's sad is this won't make you happier. So we were so early. So my first shot was in that December 2020, the very first
as
year.
a healthcare professional.
Right, which we realized we were test pilots in it. And we even, talking with a friend before this, neurosurgeon, said, boy, I hope this isn't like the swine flu vaccine where more people are harmed. And if only it were that safe. And the medical people got hit hard. 70% of the complications are traced back to 4 batches, or to 4% of the batches. And I had 2 of the really, in retrospect, notorious batches. So this took a big toll on healthcare people. And I'm not sure if there's a quality control problem or something in those early batches, but it seems the earlier you got the mRNA product, the worse you fared. And I mean, I was just hopelessly naive. I got the first shot in December. I had the month before just done the photo shoot for the Wall Street Journal what's your workout column? So that's the aerial circus arts, which is a less embarrassing way of saying aerial dance. So the point of that is that I was in really good physical shape. To be able to do that, you have to be very, very top shape.
And how old were you when you got the vaccine?
49. I'm 54 now. Yeah, so it's 49.
So you weren't even 50 years old
Not
yet.
even 50.
You're in top level condition. You're not concerned. No comorbidities. No other risk factors.
No.
Okay.
No. So I get that second shot in January, and then about 3 weeks after that, early February, almost overnight, I fell ill, and I just couldn't even walk upstairs without getting short of breath. We would not have been able to have this interview 4 years ago because I couldn't speak without having to take extra breaths in a sentence. I cannot exaggerate how sick I was. And I grew up as a kid with asthma, bad asthma. I was in the hospital a lot. And so I know what suffocation is, and I've suffered a lot, and this was worse. And for anyone out there that has been through this, I know what you have been through.
And this is a vaccine injury.
Absolutely. So
how did your colleagues respond to this claim that you're injured by the vaccine?
I knew something was dreadfully wrong, and I was able to get diagnosis very quickly because I know the system. And I first thought, I was like, well, I probably have some myocarditis, or there's an element of cardiomyopathy with this. I just have heart failure, because I was trying to do a warm-up on a treadmill. I just fell off. And the feeling you get, there's a syndrome I recognize now with this, which is you get short of breath doing things. If you go out or exert yourself, you'll feel this right chest. It's hard to describe. It's like a pressure. It's very uncomfortable. And you simply cannot push through it. Like, you feel like you're dying because you have to stop. So I was able to get diagnosed probably within a week of this. And so what I did was I had an echocardiogram, and I was looking. My training involves cardiovascular anesthesia, so I had a special certification in echocardiography. So I'm looking at the study, and I can see the left heart's pumping fine, and I'm thinking, oh, that's very good, but I guess this is all in my head. Like, this, I don't know what's wrong with me. And it's really hard not having a diagnosis. Or for anyone out there that's been struggling with this and not have a diagnosis, I truly know how hard that is.
How do you come to the conclusion that it's all in your head?
Oh, well, this was corrected very quickly. So then as the study goes on, I hear this characteristic whoosh of a heart valve. And so there's a way of measuring pulmonary pressures by blood flow through the tricuspid valve in the right heart. And I heard this whoosh, and I immediately knew that that was a fatal problem. So I have pulmonary hypertension, and so I have high pressure in the lungs, which makes it hard for my right heart to pump blood through, and I have restricted blood flow through the lungs. And that does not translate to people. So when they hear hypertension, they think it's like a normal arterial hypertension, that you just take medicines. Pulmonary hypertension typically, it usually takes about 2 years to diagnose this, because a lot of doctors will never see it in their training. It's had been very rare, 1 out of 1 million, maybe 1 out of 100,000. Typically progressive, life expectancy 3 to 5, maybe 7 years, depending on things. No treatment, incurable. And so I got this diagnosis in my hospital, and it was life-changing.
Did you report this to VAERS?
Sure, yeah, immediately.
What do you know? What do you know about the VAERS system?
I knew nothing. They didn't teach in medical school, and I asked the students recently if they're teaching that now, and they had not heard of it either. So I don't think this is widely taught in schools. So for people listening, VAERS is the Vaccine Adverse Event Reporting System. So it's the United States-based surveillance system for adverse events related to vaccines, and it is difficult to report. It's a clunky system. Even knowing medical terms and having all the information in front of me, you tend to get timed out. But I was so naive, I thought, I'm going to report this. And actually, to their credit, the VAERS people got my records from the cardiologist, and I waited, and I thought I'd talk to a person, and I never did. And then later, I collaborated with Peter Doshi, who's a faculty at the University of Maryland and an editor for the British Medical Journal, and we have an article on the VAERS system. And another incredible coincidence, I know the head of VAERS. I did not know that was his job at this time, but our kids went to school together. And so yet another amazing coincidence in this whole misadventure.
So you ended up kind of just researching what was happening to you.
Yeah.
And you connected with Dr. Suzuki.
Eventually. So my cardiologist, it's interesting. You asked how doctors respond, and the answer is they didn't know what to do. And I remember thinking, I was like, this has got to be due to the vaccine, because this is not a normal thing. The only prior way you'd ever have an acute onset pulmonary hypertension is blood clots to the lungs, and we, using the best techniques we had, couldn't detect that I had any blood clots or pulmonary emboli. So this is so strange. And so other complications that people are suffering after this, you can say, well, that complication existed before. It may be due to this, but it wasn't like something that had never been reported in medicine before. So this is absolutely novel. And my cardiologist was like, well, I don't know, what would be the mechanism? I'm like, well, I'm going to find out. And that's what led me to Dr. Suzuki at Georgetown. So I think it was met with, unfortunately, disbelief. And so my echocardiographer, just in my own town, I mean, there were one of the orthopedic physician assistants had the same problem as me, clinically the same thing. People were scared to get worked up because they're afraid they're going to lose their health insurance. I think that would probably stun people who aren't in this country, but that's how that works. Your life insurance will not be renewed. And so people were very afraid to pursue this diagnosis. And if you Google it, you're not going to like what you see. If you Google pulmonary hypertension, you're not going to like the results that come up. I think there's reason to be hopeful today. We'll get to that. My own echocardiographer had the same symptoms, and I said, well, did you image yourself? She's like, no, I don't want to know. And so there's really, you can get referral to a specialist, but that's going to launch you down a different pathway of very expensive medical treatment that doesn't have any chance of cure, and I did not want to do that. My firm belief was like, well, man created this, only nature's going to heal it. So I reported that to VAERS, nothing came of that. And in researching the mechanism, I finally found Dr. Suzuki's paper that was published the very month I got that first vaccine, 2020 December, in Respirations. And he had warned, and so he was, the premise of his paper is if you have enough exposure to spike protein, be it from either the intact virus or just from the spike protein. The spike protein is a biologically active molecule. And what he was finding is that it was activating cell signaling in tissue culture of pulmonary vascular cells. And it was causing them to divide when they should not. And he even broke that down to various subunits, that the intact spike protein would do this, but just the smaller part of the receptor binding domain would not. And that's important because one of those was a sister vaccine that was considered and trialed but not used, but we got the full-length spike protein. And that's significant because it is a biologically active molecule and it's inherently toxic. And he flat out warned that pulmonary hypertension was a likely result of this. And in that original paper, there is pathology they were getting from Ukraine. There's a connection between Georgetown and the med school in Ukraine. And we were not doing autopsies in this country, but Ukraine was. And so they had a case series of autopsies, and they were looking at how you die of flu. You die of flu because your lungs full of fluid and you suffocate. The fatalities with COVID were due to vascular overgrowth in the lung that was narrowing vessels and impeding the blood flow through the lung and eventually culminating in clotting and fatality. And so it seems that is a process just inherently linked to the spike protein and destruction of ACE2 receptors.
We saw reports of this coming out right after the vaccine. We saw those who passed away and the autopsies finding blood clots, amongst other things. You know, the evidence has been quite clear, but yet we still have these vaccines on the schedule. They're still being recommended in primary care. And this opens up the greater question about the role that the government has in making recommendations and the adherence to that by the practicing physician and their assumptions. I just got done reading a report where a survey was done where only 6% of practicing physicians fully understood the approval process for medical products through the FDA and the role of CDC. So there's
I'm surprised it's that high.
6%. I mean, it's very low, right?
I'd be surprised it's that high. I really would.
Yeah. So I'm curious to know around the training, because you did choose to get the vaccine, and I know it was it was mandated. So there's
It was not yet mandated when I did it,
okay,
but that was coming.
So why did you make the decision to do that?
Fear. I think you hit the nail on the head, is that even though we had probably already all had COVID, at the time it was before the testing was available, so we had clinical COVID, but maybe not. With anesthesia, you're right in airways with sick people. And so there's a little bit, well, this I hope will provide me some safety.
So genuine fear that you'd be exposed to a pathogen, and you would get really, really sick.
Yeah.
Can I ask some questions about that?
Yeah.
I actually am reading this book about, I think it's called Truth of Contagion, something to that nature. And I'm knee deep in history.
Okay.
And to be honest with you, I'm not fully sure that what we've been taught since we've been in elementary school
About pandemics?
around germ theory and infectious disease is entirely accurate. And there's a reason why germ theory is still considered a theory. And so much of allopathic medicine's foundation is built on really some of the work by like Louis Pasteur.
Okay.
Are you familiar with this?
Some. This is making me laugh because the same physician who taught us to accept error was one of the first anesthesiologists he was a pioneer of critical care, wrote one of the first critical care textbooks. And he would say something outrageous like this, like, well, I don't believe in germ theory. And you'd say, well, Dr. Durbin, what do you mean? And he said, well, in the Falkland Wars, they were doing battlefield surgery on soldiers outside. They had a new invention of a portable box anesthesia machine, and they could do right out in the open. Terrible wounds, contaminated. And he said their infection rate was less than our labor and delivery ward. And his point was it was the host immune response that is so important to that. And he goes, you get sick because your immune system is poor. And maybe that's what you're alluding to.
I'm alluding to two separate theories.
Okay.
There's the germ theory, which is Louis Pasteur's.
Okay.
Which got captured by Rockefellers and turned into Rockefeller allopathic medicine. So the core premise from Louis Pasteur's germ theory is that specific microorganisms invade the body and cause specific diseases, right? So I think essentially you go into medical school, why do people get sick? Why do people get diseased, right? I know we're really good at fixing broken bones and an emergency system.
Excellent point. Western medicine's great at fixing broken mechanical things.
Yep.
Yes.
But we're horrible at understanding function and why people get sick
Why
and
you get
restoring
sick,
health.
we almost never ask why.
So what's essentially happened is through that idea, we've created a system where we have to kill or prevent invading microorganisms. We've created an entire culture of fear, and the therapeutic approach is antibiotics, vaccines, antiseptics, pasteurization. Okay, putting the industries that have evolved to the side for that. It is essentially putting you at war with nature. Okay, so it's the assumption that you can make me sick. I can catch your cold. I can get exposed to any microorganism, a germ, nature, and then that makes me vulnerable.
This is very deep in our unconscious, isn't it?
Very deep in our unconscious.
Very deep.
Right?
I was thinking this the other day.
And we can look at some of the consequences of that it actually influences a greater separation from each other and nature. So we become this over-sanitized culture. Right? And in that over-sanitized culture, we end up killing off very essential microorganisms that are necessary for our health. But it turns out that Louis Pasteur's work was fraudulent.
I don't know any of this, so
I guess this is
enlighten me.
This is story time for me.
Okay, please go.
I hope I can find the notes here.
Okay.
Because in early 1990s, there was a history professor at at Princeton who was able to get a hold of all of his work. His work was held within the family, told never to be released, like the original documentation of his studies. And if you look into the background of Louis Pasteur, is he was an elitist. He made a lot of money being connected with the French government and the aristocrat kind of culture at that particular time. And there was two competing theories. There was the terrain theory, which basically is connected into the natural world, that it's the host that matters, the terrain, not the organism. So if somebody's like really sick, nutrient deficient, ill, then what does infect them, right, can kill them. Like there's some level of toxicity.
Sure.
But the truth of the matter is that the bacteria that we see, that we're able to measure, is present in healthy people, and it doesn't kill them. So this got me down the road to, and I don't know if you learned Koch's postulates, the scientific standard of germ therapy, and failed.
Excellently. Well, let's talk about that. So that was not taught in medical school, and only later did I find from one of my GI friends who's very knowledgeable, and I was like, "What's this Koch's postulates?" And it sort of makes common sense, but you explain it how you want to explain it, and I'll see if I understand it the way you do.
This is the scientific method,
yes.
Right? And so, in order for germ theory to be proven,
yes,
it has to meet 4 postulates. The first
yes.
one being the obvious one, association, right? So we're trying to create that this...
There's a disease state, and there's an organism associated
right.
with this, which I can isolate.
Exactly.
And then, and I've covered how many of the postulates there?
There's 4 of them.
Okay.
All right.
And then you have to be able to take that isolated organism, transmit it to another animal, get the same disease state.
Yes.
And then I have to be able to re-isolate that organism, and it has to match the first. Have I summed it
It's very good.
correctly? Okay.
Yeah. And what have we found? We found that that's not true. Let's use like listeria in milk, right? This is what led to the pasteurization of raw milk. And one of the things, and I drink raw milk, so I'll identify that right now, and never once been sick. Okay. And the reason why I drink raw milk is because of the...
How are you even here?
The nutrients, right? But what happened was this is Louis Pasteur's work to prove germ theory, is that a bunch of people got sick from drinking milk. Okay. And when he did his investigation, he identified, I think it was listeria, like a bacteria. And his belief was if you can kill that bacteria, you'll prevent getting sick. It was the bacteria that led to sickness. But the truth of the matter is that healthy people had the same bacteria. And it's the same thing with cholera.
I was going to bring that up, yeah.
Right? Okay. Like you can ingest, we can, into your bloodstream, we can inject cholera, or you can drink infected water and not get sick. While other people got sick. So healthy people could drink the so-called infected water with cholera and not get sick. But we saw that there were places in like cities where people got very, very sick, these isolated areas where people got sick, and then it gets generalized to everybody. But the association isn't there. So postulate 1. So the microorganism must be found in abundance in all organisms suffering from the disease, but should not be found in healthy organisms. So if a microorganism truly causes disease, it should be consistently present in sick organisms and consistently absent in healthy ones. This seems reasonable and straightforward, and that has been abandoned. There's no one study that shows this. And so even with influenza, right, you can shake hands, you can cough, you can spit into a cup, I can drink it. If I'm healthy, I'm not going to get the flu.
Unlikely.
Very, very unlikely. So it really does disconfirm germ theory. So this idea that you will get sick, this doesn't even, this is, let's put.
Maybe I can synthesize this into the way I view what's happened with vaccines, specifically vaccines. So I'm going to say this is a case where success bred excess. So my understanding as a historian and a physician is that 90% of our longevity increase between the 1800s to now can be traced to clean water, chlorinating wells, specifically cholera, and obstetrical care, and not transmitting bacteria in maternity wards.
That, I think there's one other.
Okay.
I think it has to do with nutrition.
Absolutely. And that's a component too. So I'm not going to advocate, I think chlorinating wells and water. Personally, I have a well that's clean enough that I don't need to chlorinate it. That's optimal.
Yeah.
So I would say that is where success, these are clear successes of public health, and nutrition is absolutely a component. I think that's well described in biowarfare, where a population that's well-nourished is very hard to infect, to the point where I think you could argue modern-day pandemics are probably not a thing, in that if you have modern sanitation and antivirals and antibiotics, that it would be really hard for something to truly sweep through a population. It's not going to be the Black Death that we have deep in our subconscious. Asterisk if it's a natural pathogen. And I think that's what's happened with the vaccines, is you had a clear success with smallpox. It's not around, okay?
So that goes back to postulate one.
Which is?
That whether it's smallpox or whether it is polio, there's the assumption that A equaled B. That
intervention made it less, right?
But that's not true as a historian.
How so?
So there's no evidence that the polio vaccine is what eradicated polio, and there's no evidence that the smallpox vaccine eradicated smallpox. So Dissolving Illusions is a great book to read. Have you read it?
I have not read that one.
And all you have to do, my last guest who was here was an epidemiologist, Ali Krug. And she likes to say a lot of this stuff is middle school math.
Okay.
So there's often curves that occur that when a population is exposed to some kind of, we'll call it a pathogen or a toxicity, or there's a mass of people that get sick, it tends to go in some type of curve, right? Like it rises, it peaks, and then naturally it goes down as it begins to go through the population. Less people get infected, or their bodies naturally fight that off, right? So when you get that vaccine matters on that curve using math, science. And also you have to ask yourself, for the people who have the pathogen of smallpox or infected with the particular virus or pathogen, and they don't get sick, they don't have any symptoms, why is that the case, right? You have to understand those things from a scientific method perspective, because you understand that there are multiple variables. You have to control for variables. So it goes back to like cholera. Why was there cholera in the water, let's say around New York City or major cities, as well as outskirts into suburban areas or rural areas, but it's only people in pocketed areas in the cities that got sick?
I don't think cholera was just limited to the cities. So, I'll give you an example. You can get Vibrio cholera just from the water supply of the Chesapeake Bay. So
well,
I think
you would actually have to look that. You'd have to look that up. I'll try to put a show note. And I'm not saying nobody gets it.
So I
but
finally found someone more
pandemic in one area,
more radical than me. This is good. So I thought I was going to have to come here and argue how broken the medical system was today. We agree.
Yeah,
on
not
that.
with me.
So I'll use an example of polio, and I'm going to take the clinician's view of this. So I have had patients over my career who have post-polio syndrome. And it's not a fun thing. These are kids, they were just before the Salk and Sabin vaccines came out. They had polio, they have residual weakness, paralysis, and autonomic dysfunction. And they would not wish that on people. That population is now pretty old. There are not many of them left. And I'm going to put polio in the win category. However, you will still see polio-like illnesses today where doctors will scratch their head and say you had a sudden onset of transverse myelitis after a febrile episode. Well, is that from potentially a live polio vaccine? Has there been errors in the manufacture of it? I don't know, but the sense is it's much less today. And so as a clinician, I'm willing to put that as a successful one. I'll talk about another one, yellow fever. So yellow fever used to be endemic in Philadelphia. I don't think that's part of our vaccine regimen today. I studied this because I view it as one of the safest vaccines that's around. But even still, if you give 1 million doses of this, you're going to be 8 people who either die or wish they had. But it is required for travel in other countries. My wife is looking to travel to Africa, and this is a requirement to the country she was wanted to go to. And so she recently got that vaccine and did fine. And so I support that as long as it's voluntary. Where I think we've gone so far off the rails is where these things that were successes with some problems, and again, yellow fever vaccine early on had been contaminated, I think, with hepatitis, and there was a big scandal around that, and there have been some scandals around the polio vaccine. But clearly we have crossed some point now where, for instance, the flu vaccine with each year has less and less efficacy, and this year it went negative efficacy. So you can look at it and say the flu vaccine probably caused about 1 out of 4 flu cases. There was an association with other viral illnesses, maybe up 400% with each flu vaccine. You're more likely to get another respiratory infection, and the clinicians know this. And then with the mRNA product, it's clearly creating more disease, clearly.
Yeah, I don't consider myself actually radical on this. I'm actually able to say I'm uncertain and I'm asking questions and I'm evaluating.
Yes.
So things that I've learned is the math doesn't necessarily meet what the narrative states.
Okay.
That we're told that something eradicates a condition when we don't have the math or the science to support that. Do you know what polio is?
Well, it would be the clinical manifestation of nerve damage of the anterior horn of the spinal column.
So, yeah, the challenge with this is because we have this categorization system that we use as a way to try to categorize symptoms, and then we assume it all comes from one direct source or one discrete identified disease state. But the truth of the matter is that polio was a blanket diagnosis, not that much different than even like irritable bowel syndrome or fibromyalgia.
So you're saying it was a clinical diagnosis, but easy to recognize because of respiratory paralysis or paralysis of limbs.
That occurred, but there was a whole range of symptoms apparently that got identified as polio, and when you start tracing it back to like farming practices and arsenic that was put into the soil to kill off something that would infect the livestock, for example, and then people who are exposed in that area start to ingest that food, or that actually turns out to be poison. Okay. That's where the cluster of the endemic of people who develop the symptoms that you just described that can actually lead to paralysis or death. While other people around the world, around the country, might have various symptoms that are labeled as polio but don't lead to the same outcome. And then you have people who supposedly have polio and then never develop symptoms, but it could be just a problem with the way that we diagnose, with how we label a condition. Like so I think
what you're saying is that we could miss, there could be some other cause. We're not disputing that these things happen.
Right.
And we're quick to ascribe a cause.
Yes.
And that perhaps we're missing something very important.
I believe we are.
Yeah.
And I actually think there was deliberate distortion in order to sell products. So it really, the polio narrative really did feed mass vaccinations, an entire industry. And then we need updated science to say, does the vaccination actually prevent disease? What are the harms that could be associated? What happens when you institute it into a healthy individual? And then it's not just the concept of a vaccine, it's how it's manufactured, the adjuvants, for example. One thing I just recently learned from my previous guest is there isn't really, and this is in the zeitgeist right now because I think Robert Kennedy is discussing this. We don't actually have true placebo-controlled trials for vaccines.
Correct.
Which was shocking to me.
Yeah.
because that's the gold standard science. But it's worse than that, because they set up placebo-controlled trials where the placebo was the adjuvant. And the adjuvant is what is used and manufactured in the vaccine to drive it into the body, I guess, to break the blood-brain barrier, for example. It's part of that also to preserve the live virus.
More, I think, to inflame the immune system.
Inflame
to
the
target
immune system.
Protein. Yeah.
Okay. But the adjuvants that are used are neurotoxins.
In some cases.
Yeah. Mercury being one of them. And so you're deliberately giving a neurotoxin to a population and comparing it against the product.
It's fine.
So then when you do have injuries that occur in the placebo arm of the trial, and it's not a true placebo, and it could be the adjuvant that creates the injury, they're going to come out similar, and they're going to then create the narrative that, people are going to die of the disease when they got sick from the adjuvant. So there's not really a placebo-controlled trial. And I saw this as well when I did my studies on antidepressants, for example. So what they did with the antidepressant trials is they did this whole, the placebo group wasn't a true placebo group. They withdrew them from other psychiatric drugs and put them into withdrawal. And they did that in a pre-trial.
Okay.
And they also did other pre-trial work. There's a word for it, placebo washing. So placebo washing is where you'll actually do a trial first. And so the people that respond to the placebo, you then eliminate them from your official trial. And you just keep the people who didn't. Because placebo effects are very, very strong, right? So that, when we start thinking about what may lead to disease, and we know that there's a mind-body connection, right? That consciousness actually matters. So if you believe you're sick, you believe you're broken, and then there's a product, antidepressant, vaccine, and you provided that, your belief system in itself is going to impact matter, right? It's going to create a physiological reaction, a response, something we don't talk about enough. That's why really understanding consciousness is really important in general health. So that's why you push the word vaccine. It puts it into the collective consciousness.
Yes.
But when you realize that vaccines have never undergone placebo-controlled trials, and we've never compared it with populations that never got the vaccine, like the Amish, for example. There's a reason why they don't want that to occur, because they already know the answer. We already know the answer.
I think we do.
Our current vaccine schedule hasn't improved our health. The use of vaccines in our population hasn't eradicated diseases. It's created us vulnerable to have more sickness because of the terrain theory. The terrain theory is, it is the terrain, it is your body that matters. Anything that can get in the way of natural immune health, right? And that's nutrition, that's sun exposure, that's exercise, that's connection to nature, that's your lifestyle, because that's the most important. Your body is designed to heal in that way. But anything that interferes with that natural process that's evolved over millennial is actually going to increase your vulnerability to get sick, which is why we have these rising rates of autoimmune, we label it autoimmune conditions, right? But how does the body attack itself naturally? We haven't seen that at other points in history. We see it now. So how can we not say that potentially A causes B?
Uncommon in other parts of the world. Yeah.
So does that sound radical?
So now let's talk about the real problem that's coming. So I think we're in broad agreement that maybe the testing on this has been inadequate. I learned about SSRI. So Peter Doshi, that name doesn't sound familiar to you? So he's
only from doing my research.
Okay, so he's an MIT trained data scientist and I think an anthropologist, and a very young editor of the British Medical Journal who worked at Oxford with Tom Jefferson, who was one of the pioneers of the Cochrane Collective of looking at things that really actually work in medicine. And for a while, he was very well received in popular media, and now he is not, because he has questioned many of these things. And the SSRI one, that's where I learned about the problems of SSRIs. I only learned about that 2 years ago, and he was talking I asked him, is this what you see with the FDA approval process with the mRNA product? Is this like, what's your take on that? He said, oh, this is what they've been doing, but on steroids. And he used the SSRI example, and he has a whole lecture on this. And he shows, here's the approval process for the SSRIs, and he has a picture of the stack of paperwork on the desk at the FDA, and I think it's 8,000 pages. It's several feet high. And he said, buried in this will be, sometimes you don't get all the data. If there is a negative study, they may not have to submit it.
They don't have to.
He says, he's used an example of an iceberg. He said there's so much more knowledge out there that we don't see.
Yeah.
And this is relevant to the research I'm doing with Dr. Suzuki now, is that maybe this knowledge is already there, but not revealed. So when I listened to his take on SSRIs, it was so clear that I would never prescribe one and would urge anyone not to do that based on the data that he revealed. And I think that had been known from the time of approval. Am I wrong in thinking that there was never good data for them?
Never. No. Only bad data.
Only bad data.
Yep.
So then he talks about the approval of the mRNA products. And Dr. Doshi's expertise is the approval process at the FDA. And so he dissects their own data that Pfizer, in this case, presented to the FDA. And it's right there. It's public. And it's so clear that there were more deaths in the placebo group.
Yeah.
I'm sorry, more deaths in the treatment group. I said that completely opposite. So the placebo group in the mRNA products had a better survival rate than the treatment arm, which should have raised red flags. And if we just assume that the data that the FDA got was correct, and there are people who argue that it is not, just based on the data of that approval, there's about 1 in 800 people who got the mRNA product who died or wish they had. And that's very conservative.
Do you know they abruptly stopped the placebo group?
Yes.
When this data started to come in?
Yes.
I mean, that's evil.
How do you define evil?
Deliberately trying to hurt people.
Yeah, I would say the best definition I've ever heard is taking power over others without their consent.
That's a great definition.
Yeah. I agree.
Yeah, I think taking the power away from people, but I mean, this is intentional. You know that this product is going to hurt people. Mm-hmm. Our U.S. government had this knowledge. Mm-hmm. And I did a pretty extensive podcast on this with Amy Kelly, who was working with the group, or actually she was leading the group of experts around the world who were evaluating the data once it became available from the Freedom of Information Act. Aaron Suri's work in that regard. And so they evaluated all the data and they came up with all this information, wrote a very extensive book on this. Go back and look at and listen to my podcast with Amy Kelly earlier. I wish I had the number on me right now, but I'll put it in the show notes. But it was very clear it was harmful to pregnant women. It was very clear that it was going to lead to fertility issues for both men and women. We knew that there were more deaths and hospitalizations in the placebo group. Mm-hmm. All that was known. Mm-hmm. So it always comes back to intent. Like once you know this, then you have to ask the question of intent. And sorry, I'm not buying the positive intent argument. No, this was a deliberate attack on the American people that was going to cause hospitalization, death, and disability.
So I'd like to argue against you, but I can't. I reached that conclusion later. And in the path that I arrived, how I got to that conclusion. So I share your conclusion. And I hope that doesn't turn people off for listening to this. I hope they'll hear me out. So I report this to VAERS and nothing happens. And I really did think something was going to happen. I thought, oh my gosh, because pulmonary hypertension has come up in other drug trials before. There was a drug called Epidemic that was a dye drug in Europe. And then a few years into, after it had been approved, people started developing arterial damage to lungs, and about half of them died of that. Of the people that got ill, there was about a 50% mortality rate. So that drug has been pulled. So the pulmonary hypertension was always sort of a dread complication, a delayed complication of knowing that could happen in pharmaceuticals. So I thought, as I wrote this in a very doctor way, that it would raise flags, and I really naively thought I'd get a phone call back and did not. meanwhile, I contact the reporter at the Wall Street Journal who had done the What's Your Workout column. I said, hey, I think there's a real problem here that's going to be insurmountable with this mRNA products. Can we, would you forward it to your editors? And then things got very quiet after that, and I did not understand how criticism of this is verboten. And this ties into, then it became very hard to speak out about this. And this is where there was a shift, and this is why I asked earlier, between early on, December 2020, and when you were considering this, there seemed to be a mental shift in this country where you could not speak freely about these products. And so I tried to warn about it, and you asked how physicians responded, and the answer was, I don't know the word I'm looking for. It's sort of dismissive. I don't know if there were, it was hard to convey this message to physicians, and so that's where I'm interested in your insight, is that with nurses I work with or techs, we all seem that they believe me. I think I have almost universal support, but with physicians, probably not 1 in 10 physicians are understanding what I see.
I faced the same challenge. For a while, I was providing a 16-week parent training course for parents of teenagers, and these teenagers were suicidal, self-injurious, multiple hospitalizations. Almost all of them were on multiple psychiatric drugs because that's the standard of care. And in this 16 weeks, there's some common sense recommendations around health that were made, because we see, of course, there's a correlation between unhealthy people and rise in mental health conditions. So, for example, social isolation isn't just about loneliness. Social isolation also means you're disconnected from nature, you're disconnected from sun, you're probably not moving your body, you have a sedentary lifestyle, so all these variables. So we're trying to get parents to get the kids off screens, to get them off pharmaceuticals, to eat healthy food, to move their body, to regulate a sleep schedule.
Reasonable.
Very, very reasonable. And you'd provide various data on this, and it's always the medically trained parents that provide some of the most resistance. So, for example, sun exposure.
Yes.
To try to get parents to expose their kids to sun without sunscreen.
Yes.
And how the science is very clear about how that's going to interfere with absorption of very important rays.
Yes.
And they have been conditioned to be, to fear sunburn, but they don't understand those who use sunscreen are actually more likely to develop skin cancer, unfortunately.
Correct.
Now, that doesn't mean go out there and get burned. Like, there's different ways to protect yourself, and there's morning sun exposure is the most valuable. Even in anxiety conditions, walking in the sun in the morning tends to regulate the amygdala in a way that you feel less anxious during the day. Talking about food, for example, animal products are very nutrient dense. So that's red meat, for example, and the organs of animals. And they're so conditioned, some of these parents are so conditioned by what is the narrative. Saturated fat is going to increase the likelihood of heart disease, or there's some, and this is the one that was most outrageous, is that if you ingest animal products, you're going to be harming the environment. So you have these kids ingesting all this processed food, dead food, chemically laced processed food that's labeled as healthy, and they believe it's healthy, right? And trying to get through that propaganda is extremely hard. I would never even visit the vaccine aspect of all this.
Wouldn't even touch that.
I would not even go close to that. But then trying to give them the science on
SSRIs. Be outdoors, get some sunshine, stay away from pharmaceuticals, get some very straightforward stuff.
You know how dangerous an SSRI is for an adolescent? Like, I can't even begin to tell you how dangerous.
How bad? I have a sense, but how bad?
There's a 4 to 6-fold increase in suicide, the likelihood of suicide for a teenager who would take an SSRI compared to a teenager who was applied a placebo. Stunning increase. It should be pulled from the market right there.
Is there any indication, would you, in your professional opinion, is there any indication where it's valid to prescribe it?
None.
Oh, you can't find one. Okay.
None. Because it's based on a false premise
Yes.
that serotonin, inducing the induction of or increasing serotonin in the nerve cell by blocking its reabsorption, which naturally what that's going to do, it's going to downregulate and decrease the natural production of serotonin, as if that has no downstream negative consequences, right?
Right.
So you're interfering with a very natural process. Not to mention that serotonin, 90% is created in the gut with complex microorganisms, and its impact on puberty and the developing body are pervasive.
Mm.
So you are interfering during a critical period in adolescence in a way that is a mass experiment. That's why I think the mass experiment occurred before the COVID vaccines. The mass experiment is with pharmaceuticals that are inducing changes in the body based on that allopathic model that have downstream consequences that they're never going to mention because you don't even have to study them long term. Like the approval process for an SSRI could be 6 to 8 weeks. You can have 20 trials. 16 of them can show no benefit over a placebo. But if you can find the 2, the 3, the 4, and submit those to the FDA, you can get approval. But you're bringing up a good point. It's because the medical professionals are indoctrinated into the system. But it starts way before they entered into medical school. And this was the crux of my article. Who tends to go to medical school?
Those who have been, they mean well. They want to help people.
Yep.
I told the medical students, and this will get laughed every time, no one goes into medicine because childhood was great. The amount of delayed gratification in the training it takes is simply not normal. And now, more than when I was young, it is going to be people who are selected for compliance. They'll have to jump through every imaginable hoop. And the end result will be to dampen critical thinking.
I worked in public schools for a little while, and I was able to kind of follow through with those kids that I saw in middle school who ended up becoming physicians.
Okay. Tell me about that.
And this is a
How long ago was
this is a theory. This is now. I was in public schools full time while I was getting my doctorate, actually, before I started my practice.
Okay.
Between 2004 and 2011, 2012. Before 2004, I was also doing some work in schools from various positions. Okay. But of course, I'm a public school graduate myself, so I grew up with people as well. Okay. And you have to be very smart to be a physician, but there's a level of intelligence. There's certain cognitive abilities that you have to be able to perform really high on. Rote memory is one of them, right? So rote memory or working memory is your ability to read or hear something, hold it in your memory, manipulate it, incorporate that into your long-term memory, and then regurgitate it. Right? We test that with a lot of standardized testing. Most of public school education is that it's regurgitating information that was provided to you, right? And so you're very susceptible to memorizing that information. And then in time, certain biases are incorporated. But you see that as absolute fact, as truth. And anything that would in any way challenge some of the notions of that may be met with other cognitive biases. And you would probably resist. But the other aspect about the trained medical professional is deference to authority. So school was something that was, generally speaking, was a positive experience. So their identity or their development around what they're really good at was praised by performance in school. So you have to be a good student in high school. You have to perform well on standardized tests to get into a good college. Once you get into college, I mean, you're going to take classes like organic chemistry.
It's another level.
Yeah, the most calculus.
Oh, yeah.
The most challenging courses to be able to pass just for your entrance then into medical school. But you're also indoctrinated into the system in so many other ways. You have to conduct research that's done from a certain perspective. You're contributing to the scientific literature in laboratories. You have to be able to get the highest recommendations from other people who benefit from that system. And groupthink ensues. So before you even take a step into medical school, you've been indoctrinated from cradle all the way to, the time that you're, 22, 24 years old, whether time you enter medical school. And then, my goodness, what you face to have to go through medical school, incur that degree of debt, go to residency.
You're now, there's no backing out at that point.
You're slave labor for a very long time. Right? And then when you do graduate, yes, you have this ability to make a substantial amount of money.
We're talking graduation from medical school.
Yeah.
No.
From residency.
Now residency.
From once you're able to practice
medical
independently.
Medical school was relatively fun. Then the hard work begins.
Yeah. And residency, what we do to medical professionals in residency is inhumane.
Yes.
But my point was being that once you eventually are independent and you can practice, you have to work really, really hard. You have to pay back, most people have to pay back student loans. And now you want to be able to achieve a certain lifestyle, at least financially, from all your hard work. It's very difficult to be completely independent working in the American healthcare system.
Almost impossible.
And that's where I think it was breeding ground for complacency and just repeating what the government narrative was, because you've been mass conditioned to believe that the authority figure and American healthcare system is supreme. This is the beacon of scientific supremacy, and everything they've been taught and everything that they learn is gold standard science. There's still always science evolves. I'm not saying they don't believe that science doesn't evolve, but what they know is the pinnacle. And then so when these government recommendations come out and they're following protocols, there is almost blind trust on its safety and its efficacy, and they end up repeating it.
I would just remove the word almost. Yeah, there's blind trust. So these are great insights, and I wish I had these before I gave my second talk at Georgetown, because now we have laid out why it went so poorly.
It's possible that COVID-19 wasn't even actually a pandemic.
True.
If we think critically, right? And this is all I want to do, is I want to make sure people who listen to this podcast are thinking critically. So here's some data. So there were millions of what we call asymptomatic cases.
Yes.
Right? So much so that somewhere between 30 to upwards of 80% were people without symptoms. And healthy people routinely carried high viral loads without illness. And there was this age stratification, which showed dramatic differences in outcomes based on age and comorbidity patterns. And we had no evidence that the people with the high viral load actually passed it on and infected another person.
I haven't studied that, so I haven't looked at viral loads or transmission.
Yeah, so it's possible, like, you could be a healthy person, have a high viral load, be asymptomatic, and you can't infect another person. But we were drilled into it, and that we were. And then they used the testing mechanisms, the PCR tests, which only tested the viral load, or I could be wrong on that. But the PCR testing in itself was not accurate.
You can infer on how many cycles it has to run the degree of load, but it's not probably a valid way to do that.
So we had all these people identifying, and if you can go back to CNN, you saw the running clock.
Sure, we had a pandemic of testing, yeah. So, I mean, were some people demolished by this virus? I mean, there were definitely people who were very harmed, and so the research I do now, going back to the spikeopathy, is that there is a clinical syndrome I see now that I see daily, at least weekly, sometimes daily, of some version of what I experienced. And this is what I was trying to convey, was perhaps we now have, so all the problems we know about this product. The paper spikopathy, this came out in 2023 under author Perry in Australia, and it's 80 pages of cataloging the harms of this. And there's a problem with the nanoparticle. There's a problem with synthetic mRNA. There is a problem with the thing you load into with the product that it's going to make. It's going to create autoimmune problems, but then you create the spike protein and it's going to create its own set of problems. And it seems unbelievable how would a simple country anesthesiologist and a bench researcher at Georgetown have insight into a disease process that had been so rare but may be affecting a large portion of the population. You yourself, do you know people who either had COVID or got the spike protein product who are just short of breath doing things? Looks like Bethlehem's a pretty hilly town, I imagine. Maybe you've seen some of that. What have you seen?
Well, I've seen, and I wanted to ask you about this too. I've seen people who identify with a range of symptoms that are now characterized as long COVID.
Mm-hmm.
And that could include that, what you just mentioned, is that same experience.
Mm-hmm.
What do you know about long COVID and
Sure.
potential results of that?
Sure. So if there's damage to the pulmonary vasculature, there's going to be a set of symptoms you get. And you're going to notice it the more exertion you do. And so the physiology simplified is this. As you and I are speaking, blood is flowing to your right heart, through your lungs, through the left heart at about 5 liters a minute. The pulmonary vasculature is wide open. If you spread it out, it's thought it would cover the surface area of a tennis court. So it's a very high flow, low pressure system. And the right heart is oriented with longitudinal fibers, so it responds very well to changes in volume. So if you stand up so quickly, it doesn't bother you. Or if there's a sudden blood return to the heart, it'll absorb it. The left heart is designed with concentric fibers to pump a high pressure. If you're an athlete and you exercise, it is possible to get your blood flow through the right heart, through the lung, to the left heart, and then out to the tissues, 25 liters, 30, 35 liters a minute. So it's such that blood can be traversing 1 liter through your pulmonary vasculature every 2 seconds. It's incredible physiology. But anything that is going to impair that blood flow through the lung is going to limit the flow through the left heart, and it's going to impair your ability to exercise. It will decrease your aerobic capacity that's measured by VO2 max. And I can see, so what happened to me was I felt very, very ill, and the pressure in my lung was high, and my ability to exercise was severely impaired. It was hard for me to even stand. It was hard to walk even 3 miles an hour would be a big exertion. People describe me as ashen, gained a lot of fluid, 15 pounds of fluid, felt like I had a headache all the time, and the fatigue was simply overwhelming. And any kind of exertion, I just get this pressure in my chest. That very uncomfortable. It was about 4 months before I could even lie down and be comfortable. So the misery is just so hard to overstate. And I survived it. But what's amazing is that 1 year I thought, I am surely going to be one of the very rare people where this pulmonary hypertension has reversed, because I'm able to do more stuff. I was able to walk hills, even run very slowly, not great, got back into the circus arts slowly. And that 1 year, the pressure had not changed. Over 3 years, I have more endurance. I can do more things. I can run some. I can ski again. I can go to altitude, which is a big no-no, supposedly, with pulmonary hypertension, but I'm able to do it. I still have this high pressure. And the amount of lung vasculature I have lost is the equivalent of if I had a lung taken out. It's what you'd expect after a pneumonectomy. And it's hard to convey this to people because you're probably looking at me like, he doesn't look unwell. I had a lot of damage. And this is hard to convey to people out there who say, well, I got this product and I'm probably fine. And I ask, well, how do you know that? Are you sure? And it is just stunning what I see in my practice among staff and patients is how many people are short of breath doing things, and they end up either going to a lung specialist, and they will have normal pulmonary function tests, but maybe come out with a diagnosis of asthma even though they've never wheezed.
So it gets attributed to other causes?
Other causes. Or they'll see a cardiologist. And the left heart is pumping fine. They'll even have a clean stress test. The arteries that feed the heart are fine. And there's a shrug. There's a lot of arrhythmias that come. I had a lot of arrhythmias early on too, palpitations, which has since passed. And I'll look on the echocardiography report and I'll see near diagnostic or close to diagnostic pulmonary hypertension. And the reason it's so confusing to doctors is we need a better name, because the problem is it's impaired flow through the lungs, okay? And it will be labeled mild pulmonary hypertension. And even though mild pulmonary hypertension doesn't sound bad, but you're still talking with something that has a life expectancy of under 7 years and usually progresses. And it's very hard to convey the seriousness to even other doctors, let alone people outside of medicine. So my premise is that of anything that's going to impair blood flow through the lungs, if there's a narrowing of the vasculature, if there's an overgrowth of pulmonary arterial cells, that any impaired blood flow is going to be first noticed by the athletes, and you typically see this.
And we have seen that.
You have seen it. And most of the athletes I know would say, oh, my times are much slower now. The wattage I can do on a cycle is down. And they would usually recover over a few months. But what was really interesting, and this is the point of long COVID, is there was one group that looked at long COVID patients who were short of breath doing things. And it's a small study, and I sent it to you. It's the one from Italy. And it's only 20-some patients, but every single patient in that study had pulmonary hypertension. And the reason this is so remarkable is that if you have acute pulmonary hypertension to the point you make the diagnostic threshold, where the pressure, they define it as a mean pressure in your lungs of 20 millimeters of mercury. It used to be 25, they lowered it. But if I were to do that acutely to you, if you were to throw a blood clot to your lung, you're on death's door. Many people will not survive that. So by the time, if you have, usually pulmonary hypertension would come on over years and would give the right heart time to adapt. When it happens acutely, your right heart does not have time to adapt. Now, if you're an athlete, you have a better chance because your heart has been working, doing more pressure and volume work. So really trained athletes will actually have a little right heart hypertrophy, and that's probably what will save them. But what was remarkable in that Italian study is that at 1 year, they followed these patients with long COVID, and over a year, they got a little better. They could do more stuff. They could walk further. They felt better. And they would go and measure them, and they were using the gold standard, which is using a right heart catheterization. So they measure the pressure directly in the pulmonary artery and in the right heart, and they still had pulmonary hypertension. And so it is possible we've had a sea of damage out there. What's unknown, and this is with people who had COVID, okay? So the question next is, and this was Dr. Suzuki's hypothesis, well, we're seeing this in COVID. If you look back, and he was researching that because he was looking at SARS. It was known with SARS-1, if you just took the spike protein component, you could recreate the disease in the animal without the virus attached. It would cause the disease. So that's why he thought to research that. And then we see pulmonary hypertension in the autopsy. We see lung vascular damage in the autopsies. You see it in the tissue culture that he was using. And then I'm the human correlate of that. And the question is how much out there? Am I unique? Or is this something that's broadly happening to people?
And so you were a case study.
I'm the first, yeah. So so the question is am I very unlucky? Or I'm an example of a spectrum more severe, but a spectrum of things that's happening? And then the next question is this an inherent property of the spike protein? And what's very worrisome is that there was a study with middle-aged cyclists with who were trained cyclists with, for their age, a good VO2 max, a good aerobic capacity. And they gave them a booster shot, and they measured their aerobic capacity 1 week after the booster, before and after. So presumably they had already had mRNA product, and they were using, I think, the Pfizer mRNA. And at 1 week, that group in aggregate had a drop in their aerobic capacity that was what you would expect to see of 5 or 10 years of aging. And what's unknown, and I wrote the authors never heard back, like, well, why do you think this is? It's some impaired oxygen delivery. Either blood's not going through the lung or mitochondria is not using the oxygen. There's some problem. And does it get better? And as to my knowledge, that there's no answer to that yet. And then most worrisomely is the current research at Georgetown, where if you just replicate the experiment with SARS-1, instead with mice, we're using rats this time, and you take just spike protein, no adjuvant, and inject it into the abdomen, the peritoneum of the rat, you can induce vascular damage, profoundly so. And so I hope this study is published. It should not be hard to replicate around the world. It's not particularly difficult. You're seeing pulmonary vascular damage, right heart compensation. There's some changes in the heart muscle. You alluded to before, we weren't looking at placenta, but it's known that human placenta is damaged from COVID, from SARS-2. And there are one of the collaborators with this, who the cardiologist, pathologist, looked at the brain slides of the experiment, and the same process is happening in the brain.
I had Dr. Michael Nels on the podcast.
I don't know who that is.
He's German.
Okay.
German physician researcher.
Okay.
And it was his belief that the mRNA gene therapy was a bioweapon. So I know we talk about like COVID-19 being the bioweapon, but I think his hypothesis was the mRNA technology is the bioweapon itself. But he was talking about the role of fear. And I've had a number of holistic health practitioners, practitioners who have been on death's door, terminal cancer diagnoses and so forth, who have had what's called spontaneous healing or medical miracles, basically sent home to die, or modern medicine in itself could not identify why they were so sick. And there's an emotional component to healing, an emotional component to disease is what it comes down to. And a lot of people had to face fear. They had to face previous traumas. They had to employ forgiveness. There was a faith aspect into their healing. But it was only then when they surrendered to that with courage and faced those things did they see like spontaneous remission or healing when the allopathic model in itself could not. And what you saw with COVID was fear induction as a strategy. You even said, well, why? I asked you the question, why did you take the vaccine? You said fear, right? And it can be fear of contagion. It could be fear of the unknown, trust in the medical authority, fear for your job, whatever that may be. But the core aspect is fear. Do you think this is an opportunity for us to step back and look at our paradigm and maybe even look historically about how previous generations and other cultures have approached health and healing? Because it's very clear that the data that exists in our country is that what we're doing is producing poor outcomes in comparison to other cultures.
I'm going to quote Jeffrey Tucker of the Brownstone Institute when he says, "This wrecks society." We're not talking about a small thing. I mean, it's been stepwise with everything you described about the medical model is failing. And I hope I'm wrong about what I see, but essentially this will be a mass poisoning. The only question I have after researching this for 4 years is I don't understand why more people aren't sick. I'm glad more people are not sick, but this, we can ignore it, but the reckoning is still coming. And what I'm advocating for, and I hope what comes out of this, is that one, people who are suffering these effects know there are people that believe them, because I think a lot of people, it's dismissive and it's psychologically very harmful. And I hope you and I together I think we have an opportunity to do really alleviate some of the psychological suffering and even help with the medical harm. I think one of the things that's really keeping doctors from looking at this is the sort of futility aspect. Like, you have this diagnosis, we can't treat it. And what's amazing, and which is a blessing to me, is so Dr. Suzuki has been able to reverse this in animal models going back 20 years. And I asked him, I said, why doesn't this make clinical practice? He said, well, I'm not a clinician. It just stopped there. So this shows that gulf between bench and translational research. And it's puzzling to me that people will treat in pulmonary hypertension clinics. I would think they'd be really interested in curing patients, but there doesn't seem to be a lot of interest in curing medicine. I know that doesn't surprise you, is that you might lose your patient, right? Like, you want a medicine that you can prescribe all the time, right? I'm interested in cures, and I hope that comes out of this, we face this head on. I hope we're at the point we need institutional support. to the study in Italy was 21 patients. I'd like to see that replicated here with thousands and really get a handle on what's going on. The amount of vascular damage is, I mean, we see so many strange diseases now and things that I've just never seen in medicine before. I've seen in the last few years. And I presume it's traced back to this product. And to your question is I mean, the model is now beyond broken. I mean, patients aren't going to stand for this, I think. What do you think?
There's a pervasive distrust that's part of a general awakening.
Yeah.
And I actually think that's ultimately positive because I do believe the model's broken, the paradigm is broken.
Yeah.
So I'm less interested, and I feel horrible for the people who have taken the vaccine, but I'm interested about future generations preventing this from happening again because I think we're at risk.
Oh,
and we're vulnerable.
This is so bad is you have to ask yourself, does your civilization move on? As a historian, I ask this question. Do you have a civilization after this?
It is a lesson in groupthink, and I think we have to...
To the extreme.
To the extreme. I think that's the lesson that we have to reflect on. Irving Janis, I think, coined the term 1972, and what groupthink means is it's the practice of thinking or making decisions as a group in a way that discourages creativity or individual responsibility, resulting in poor decisions. And this is what has been used as a weapon against us as well, because these are characteristics of medical groupthink. The first one is the illusion of consensus, right? That all dissenting views are suppressed or ignored. Silence is interpreted as agreement. So those who are not yet sure, who don't speak out. And medical consensus appears stronger than it actually is because the mass censorship that exists from that large industry that benefits from it. So with social media and with the internet, too many people use Google to get information, but they don't realize that what's provided for you in the first few pages of Google is very controlled information, paid for by industry, right? So all of that is served to you to influence your bias and influence what you think. All those websites on WebMD and across the board are funded by industry. And I think the evidence shows that most people aren't going past the first 1 or 2 pages of Google to get information. So it's provided to you and there's an illusion of consensus. So that's a major aspect of medical groupthink that we have to be aware of. Self-censorship was another one. Oh,
sure, yes.
And which was the major problem in your community as a medical professional and physicians, that members avoided raising contrary evidence. Now, you're not doing that. You're lecturing. And physicians don't voice doubts when they have concerns about protocols. Fear of being seen as difficult, unscientific, right? So you end up adhering to what the group thinks, even if you have legitimate questions. My big problem with SSRIs in primary care is doctors don't really have the choice to not prescribe.
You talk about that in your article, yeah.
That's medical groupthink.
That's corporate medicine.
That's corporate medicine, which is a form of medical groupthink. There's the pressure on dissenters. Those who question are marginalized.
Oh, for sure.
Right?
I'm considered a fringe physician by my own daughter.
Interesting, right?
Yeah.
What I found fascinating about the time is somebody who has very little background in anything thinks they're experts just by absorbing the narrative. Right. And that's the thing. When I try to provide people information about psychiatric drugs, there's going to be a percentage of people just think I'm a quack. Not because they know anything or read one study or know anything about it.
But you have a minority view of the thing.
Because it's not the majority view. Right. And I've invited so many people to come onto the podcast to debate me on this, right?
Really?
You just don't get it.
They won't do it.
No, they're not going to come on. Yeah. I put myself in a small category now because I got obsessed with the research. I mean,
well, it's important because for the same reason I'm studying. Would I study this if my life depends on understanding And I hope I live a long life, and I think I will. And I'm able to do things that I enjoy life again. I really am happy, and a lot of that may be because I did different things than what would be recommended for my condition. And you had to study the SSRI to really understand it, to say, can this really be this bad? And people question me, you must be misunderstanding it.
Yeah.
There must be something, you must assume positive intent. There's something you're missing. You cannot be right about this. And you had to study the SSRIs, and you see it firsthand. You see the damage. You look people in the eye. You know it's wrong, and yet it still keeps happening. And you've known about it for 25 years. And yet, you present a very persuasive argument. I was already persuaded by Peter Doshi, but you know, I've read your work on it. It's persuaded me. And I guess I don't know how the system changes. It's almost as if people have to be rescued from it. I'm left with 2 books from history. There's one, Fear of Freedom, and the other's The True Believer. And I think in this country we have lived through a big lie, and I think it's very hard for us to realize that things that have happened in other countries have now happened here. And I would like to say everyone would wake up at once. I really hope you're right about it, a spiritual awakening. I pray that we see that. Some of the work that may have to go with how to treat damage from mRNA and damage from COVID, it may be other countries that have to do it. I'm not sure it's going to happen here. I hope it does. But we almost need someone to rescue us from this.
Yeah, I think we're going to have to save ourselves. We can't wait for anyone else. I think this is interesting because there are conditions that foster medical groupthink.
Such as?
One is high group cohesiveness. So a strong professional identity and shared values. You know, we're all in this together type of thing. Intense training creates tight bonds. And then you see this in like what you do with the Navy SEALs or our military, for example, is you put people through hell.
Sure.
They survive hell. And, you know, there's a deep sense of like trust in other people who've kind of gone through it. You did a great job of talking about, you know, just the experience of a medical professional, what you have to go through. I think that does create high group cohesiveness where you trust each other and you trust each other's opinions. The second thing, and this is an important one, which is a major problem within our system, is there's insulation from outside opinions. I've looked into holistic health literature, naturopaths, functional medicine. I'm very interested in alternative views of treating chronic disease. We have a chronic disease epidemic that is certainly like part of like range of metabolic conditions, but these dramatic rates and increase of cancer and so forth. We're just getting sicker earlier. And so I'm looking for these other opinions, and I was just completely surprised the degree of strong scientific data that exists outside what we would say are the top journals and our exposure to Western medicine. Like very convincing research on things like the biofield, consciousness and health, emotions and health, a state of balance with nature, microorganisms, microbiome, and all these things that are, you know, very important for the makeup of the body to seek out homeostasis, and how they're just suppressed. Even like problems with antibiotics, the use of antibiotics, things that are just very well understood. Vaccines, of course, are in that. The questionable research, whether viruses actually exist as something that can infect somebody. Like just so much interesting work that's being done. And I'm not saying that to be a conspiracy theorist. I'm not saying that all this is absolutely true. What I'm saying is if you're in a society where you cannot talk about it, where you can't openly debate it without being called a name, when it's actively suppressed, when you have an apparatus from Hollywood to the media that pushes ideas on an entire population and then it cultivates fear, that fear is influential in disease. When you've evolved to a stage where healthcare is only writing prescriptions for pharmaceuticals,
Yes.
synthetic chemicals made in a factory, a lot of them which don't have strong scientific efficacy and a significant amount of harm, and then you accept it as healthcare. That's because we've been insulated from those outside viewpoints.
Yes.
And when you have physicians that aren't even exposed to nutritional training.
Correct.
Right?
Still.
Yeah. Now, Robert Kennedy just this week said he was going to mandate it as part of medical training. But again, that's coming from the government. It shouldn't have to come from the government. Right.
I'm skeptical of all mandates now. Yeah.
Three other things that are really influential conditions that foster medical groupthink. It's what's called directive leadership. So directive leadership is a clear hierarchy with strong authority figures, top-down decision-making, and questioning leadership is professionally dangerous. So you see this when it comes down from government, CDC, FDA process and setting guidelines. But more important is the thought leaders that are actually paid for by industries to push ideas that foster their products. And those people are unquestionable experts. Like that's why the word expert can be very problematic. Right along with that is the lack of what's called systemic decision making. So protocols are presented as unquestionable. No formal process for challenging guidelines. Evidence evaluation done by authorities, not the practitioner. And if you do not follow the protocol, you are then liable legally. So even if the protocol influences malpractice, like following the protocol and your patient dies or gets injured, you're not liable for medical malpractice. If you go outside of the protocol, you're vulnerable.
That's a fair statement.
And this is what the pediatrician told me. He says, I know that antidepressants provided to a teenager who's suicidal are going to increase the likelihood they're going to die by suicide. But if that teenager does die by suicide, and I did not offer an antidepressant, then I can lose my license. And then the last part of this is high stress with low hope. So crisis situations increase deference to authority.
Yes.
Emergencies justify suspension of normal critical thinking.
Yes.
Like the COVID pandemic created the perfect groupthink conditions because it provoked that fear. It's a crisis situation. You needed to follow the authority. You were scared to death to step outside what was the prevailing narrative because the risk is higher too. Imagine also being a medical professional who's in a position to treat somebody who has COVID, and you're told that a way to get out of the pandemic is to follow these steps and to get the vaccination. You put yourself liable, you put yourself at risk if you step outside of that.
Still.
Yeah. And I think that is the takeaway from your story. That's the takeaway from the past 5 years that we've been in, is that if we don't take a hard look about how our minds were controlled and how we were behaviorally controlled and conditioned, then we are going, as a society, we're going to move closer and closer to extinction.
We're in deep trouble. I agree.
Do you know who Zach Bush is? Mentioned him on previous podcasts. I'm fascinated by his work. He's a physician who's kind of pulled himself out of the system because he himself just disputes many of the accepted paradigms of allopathic medicine. And when you look at the data, we are moving closer and closer to an extinction event.
Meaning that life expectancy is shortening or birth rates are down. What do you mean?
That's it.
All the above, right?
So when you have the life expectancy shortening, the birth rates are decreasing. So you're not populating the earth with the amount of people that are dying. And we see a fertility crisis. The fertility crisis is here. I think there's a 50% decrease in sperm count just over the past 25 years for men identified. Women are having a harder time becoming pregnant.
Do you think this is economic, physiologic, or both?
I think it is a direct result of being poisoned for almost a half a century.
Through a myriad of
mechanisms, including us being further and further disconnected from nature and from ourselves. So we've evolved to be connected with nature. And so we're working under fluorescent lighting, circadian rhythm disruption, lack of light exposure, connection to nature. We're killing microorganisms that are there for our health. We're in a battle, with our own minds, with our own emotions and our own health. And we've cultivated an entire culture based on fear. And an entire system is there to treat that, with billionaires getting richer and richer and then controlling the narrative further and further, as well as controlling our politicians. And so it is through conversations like this, it's us. When I write, I'll often end my Substack articles by just saying resist. And that's what we have to do. You have to resist the ideas. You have to resist the control mechanisms. So I'm one of the few people that talk about mental health has been co-opted to get you to be in a war with your own emotional states. This is an experiment. Like your own emotional reactions are now to be invalidated, drugged, which are extremely important messengers to you to face, solve problems, and get healthy. Like justifiable anger is an important one. Right? I'm sure you're justifiably angry.
I've passed that stage. I'm to the humor stage. It's so broken, I just laugh at it now. I mean, I don't mean to belittle anyone's harm, but I've been watching this for 4 years, and maybe you'll understand this. So in my talk, I started both with the quote about my mental disorder, about laying out enough facts in the right order, and then just an observation which I made offhandedly. I said, look, my observation is that there's a great divide in this country, and if you think that the COVID came from nature, if you believe that, you're going to have a worldview where everything the government did and our response to it was good, and the only thing lacking was we need to do more of it. If you think this came out of a lab, you're going to have a very different worldview. And I presented evidence. I said this, obviously came from a lab, which I guess was the wrong thing to say there. And so the next one, I followed up with Dr. Suzuki. Said, "Yeah, you maybe not have realized you led with that, and that was probably the wrong thing."
No, it was the right thing.
I'm an old doctor, but a young lecturer and a young researcher. And I said, well, what do you think was going on? He said, they're just fearful for all the reasons you talked about.
Yeah. On
some level, they know.
Yeah, I ultimately felt let down by humanity.
Yes, I have seen enough. I have seen enough, yes.
And I felt...
Tell me about that, yes. Tell me more.
Let down by our medical providers, our medical establishment.
Yeah.
And listen, I'm a reasonable person, and I've talked to some of these primary care docs in my field, and I know they believe they are doing the right thing. And they're still recommending the COVID vaccine. I have 3 adult children now, but my oldest was quote unquote being mandated to have to get the COVID vaccine to stay in college.
Yep,
we fought it.
Mine too. Mm-hmm.
We fought it, and she was still able to take classes. She had to go through all this testing protocols all the time.
Okay.
It was nonsense, but she got through it without becoming vaccinated. She's also a medical professional. She went and got her doctorate in physical therapy. She just graduated, and through all her different placements, the same thing. You're mandated to get this, and she resisted.
She avoided it. Okay.
Yep, we actually sent her to Orlando to do one of her clinical trainings because that was the one hospital that was part of this network through Temple University that was willing to have her work there, because you have to do a hospital rotation as a physical therapist, where it still wasn't expected that you get that. I mean, and we don't even get the flu vaccine, so it's like resisting all of this. And when you resist, you put them to have to defend themselves, and a lot of them don't have legal standing to mandate this. But people just comply out of fear.
Yes.
And that's what I see. Once you resist, you make them have to defend themselves instead of you defending yourself.
Ooh, that's good insight. How would you approach that with the schools? If anyone else is going through this, how would you approach that?
Well, I'm doing it right now. Also, my son is actually leaving for Bucknell University on Sunday. He just graduated high school.
Okay.
And I mean, we're not getting the meningitis vaccine because of data.
I haven't researched that one.
Yeah. He's a Division I athlete. He's a wrestler. Like
Okay.
the likelihood that he would die of meningitis is lower than a vaccine injury.
Okay.
So that's why like relative risk factors are so important. Again, I'm not even sure about germ theory, so that I would put my own healthy son at risk is beyond me. So we'd resist that. You realize that state of Pennsylvania has mandated that meningitis vaccine. All you have to do is dig a little bit deeper. They have 3 exemptions.
Okay.
One is religious exemption. One is philosophical exemption.
Okay.
And another is health exemption.
Mm.
So we have a philosophical one.
Okay.
In fact, I would say like the reason he shouldn't get a vaccine is because he's healthy. Like, and that's the where everything's upside down. If he was immunocompromised potentially, right? There actually might change the relative risk profile, because then you're at a higher risk of severe complications from meningitis. But a healthy person is not, and that's why these mass vaccinations are so problematic, because we treat everyone as if they're the same. And it just like kind of back to something you said earlier when you were treated as a robot. People are sometimes treated like they're robots, like like we're all mechanical and the parts don't work together. And ultimately, I'm concerned about the anti-human transhumanist movement. That's the evil part behind this. I don't think they have any indication, or I don't think they care at all about transmission of disease. I think there's a real, genuine agenda to depopulate. And it's been written about. It's not like it's a conspiracy theory. You can find the videos from major players in the World Economic Forum talking about the concern of overpopulation. And they use that we're killing the planet and other bullshit things to support it. But it's just another eugenics movement. It's anti-human. Yeah. And somehow these sociopaths believe that with AI and other technology, we could enhance humans. We can optimize humans.
I listened to that podcast of yours.
I fundamentally don't believe that.
I agree. I think they may be creating their own new circle of hell.
I think it's been going on for a long time. But listen, I've had you for a long time. We've talked about a lot of different topics. I guess I just want to close on this. What is next for you? What are you going to continue to do professionally with what you've learned throughout your entire experience? How's it better going to serve your colleagues? How's it going to better serve humanity?
Ooh. I think just meeting here today, I think we've done a service. I hope we have. I pray we have. I will keep pursuing this research for as long as I can, and mainly speak the truth. And I will keep going as long as I can.
One other thing we're going to get to.
Okay.
How do we heal from all of this?
Well, those are 2 questions. I was going to say, how do you heal from the trauma of medical school and the medical training you were asking? And I spoke to that with the students. Is I think the most difficult thing for me is you are taken out of the moment, out of the present, out of your body with all that training, because you have to it's just physically uncomfortable. You're sleep deprived. It's not fun. It's delayed gratification. You are always thinking about something in the future. And so anything that will get you back to the moment, and it could be anything, but it's got to be creative. It's got to be some art. And that was, for me, yoga, and then mistakenly getting into the circus arts, which I thought was aerial yoga, and it was not. It was something I didn't realize I was signing up for, but I stayed with it. And it ended up being a creative outlet that was very healing, because it got me back in the moment, back in my body. And I can't believe I ultimately ended up performing. I hate being in front of people. I'm not comfortable in front of audiences. Normally I'd be very uncomfortable in even just this kind of talk, but it started a journey that was very healing. And so that was my message to the students is don't lose touch with that. How do we heal from this trauma? Oh my gosh. I think by admitting error, I think that's a big start. You may disagree, but I think if my profession were more honest about, with humility of we got this really wrong, I think there'd be forgiveness there. But I think the admission of error has to be first. It just can't be blanket forgiveness and going more about the same thing. There must be a radical change. And I'm here speaking with you today. My initial prognosis was probably 100% mortality at 18 months. And I decided I was not going to be a lab experiment. I was not going to subject myself to that model anymore. And by several moments of grace, people came into my life that were tremendously helpful. I have a friend that does traditional Chinese medicine and looked at me and said, "You don't look well," and hand-delivered medicine right away. And within 3 days, it took the pressure off my chest. And so it's fun as a scientist to look at what were the components of that, and there were things that were very active in my condition that were going to be helpful, vasodilators and probably some agents that were antimitotic that probably helped arrest that process to some degree. The other person in my case report, I was sicker than him, I got better than him. He's been about the same, and now it's getting worse now. So I worry about that because he's progressing. And I think there's reason for hope, though. There's other alternative things. Right now, the current state of treatment for pulmonary hypertension is about $250,000 a year. It will bankrupt you. But I didn't do that route. And so I was able to find there are other off-the-shelf compounds. Some are from nature. Some you can get right off over the counter at a health food store. Some that are prescription, but it won't surprise you that things that upregulate the ACE2 receptor actually have been shown in models for pulmonary hypertension to treat it. You'll recognize hydrochloroquine, ivermectin, doxycycline's another one, and those have efficacy in upregulating that receptor and probably is helpful in that. If we were to have another round of COVID, if there's sick COVID patients now, I would advocate most of the disease seems to be from destruction of ACE2 receptors and interrupting that physiology. And I would hope doctors would look more at looking at maybe alternative non-mRNA products. So treating the disease, and as you mentioned, everything just from having a high vitamin D level, you're very unlikely to be sick from this. And then alternative treatment would be infusing recombinant ACE2 receptors or the product of that ACE2 receptor. So if that ACE2 receptor is not working, you get too much angiotensin. It can be the product of the ACE2 receptors, angiotensin 1,7. It can be infused. That's been done experimentally. I hope researchers in this country, if you're a patient that is suffering with this and a doctor that's puzzling over how to treat it, really give a hard look at is pulmonary tension behind this shortness of breath if it's troublesome to someone. And if it's not showing up in the echocardiogram, you may have to do a right heart catheterization. And if you're someone that gets this diagnosis, please don't lose hope. The fact that I'm here talking with Roger is a sign that I think we can fix this. And I would love to see Dr. Suzuki get some more funding. I mean, if it could be a GoFundMe page, I hope he gets institutional support. But he's a brilliant man. I think his work is deserving of Nobel Prize. You'll be embarrassed to hear me say that. He's a very modest man, but truly a genius. And he is they've both been able to reverse this disease process with inexpensive drugs in animal models. They have shown right heart cell recovery and repair of scar in the heart in animals. And so I think I've been so lucky to meet such gems of people, and even though something very bad happened to me, at every turn I keep running into great people, and I think you're one of them. So thank you for having me here today.
Thank you. I'm so grateful for your willingness to reach out to me and tell your story. I certainly believe that a lot of people are working for good now in response to what has happened, and that's an important piece of it. So telling your story, questioning the orthodoxy, demanding answers, new research, being vocal about it, lecturing, all those are part of the process. And so very grateful that you're willing to come on and talk about this, and thank you for a radically genuine conversation.
Thank you.